Hello students, welcome back to Exam Key Point Dentistry. Today we are going to discuss a very important topic in oral surgery, that is the condylar fracture. This topic is very important for BDS exam, Viva, university theory and clinical understanding, so watch till the end. So now we will study the classification of condylar fracture. So first one is unilateral or bilateral condylar fracture. Here unilateral fracture is only one side, condylar is fracture, okay, and bilateral is the both side condylar is fractures. Now the second one is Rowe and Killey's classification. So it is divided into three. Simple fracture of condylar means only bone is fracture, okay. So here bone is fracture, skin and mucosa are intact. Now the second one is compound fracture of condyle. Here the bone fracture with communication to outside environment. Now the third one is community fracture associated with a zygomatic arch fracture. So that means the bone is broken into the multiple pieces. Now the third one is Rowe and Killey's classifications, which was given in 1968. So the fractures, classification based on the anatomical level. So first one is intracapsular fracture, intracapsular fracture or the high condylar fracture. So here the fractures occurs inside the TMJ capsule. So it includes fractures involving the articular surface, fractures above or through the anatomical neck which do not involve the articular surface. Now the second one is extracapsular or low condylar or subcondylar fracture. Third one is fracture associated with the injury to the capsule, ligament and meniscus. Fourth one is fractures involving the adjacent bone. Now you can see in this diagram, the upper part is the intracapsular fracture and the lower part is the extracapsular fracture, okay. So intracapsular fracture, the fracture line is inside the joint capsule. So you see a line is drawn that is inside the joint capsule, and the fracture line is below the capsule in the neck region. So it is a extracapsular fractures. Now according to the Maclennan clinical classification, so first one is, there are the four types, okay. So first one is no displacement. So here a bone is fractured but it remain in position. You see it remain in position, okay. Now second one is deviation. There is a simple angulation between the condylar neck. This is a condylar neck and this is a ramus. So here it is a simple angulation you see, okay. Now the third one is displacement. So here is an overlap. This one is overlap. So here overlap occur between the condylar process and the ramus. So in this diagram you see a fragment overlap to the each other, okay. Now the fourth one is dislocation. So condylar head completely come out of the glenoid fossa, okay. So here you see, suppose this one is glenoid fossa, so it is completely come out of the glenoid fossa. So in this diagram the head is outside the joint, so it is very important for the Viva. Now according to the Wassmund Classification, so type 1, the angle between the head and the ramus is 10 to 45 degrees. So type 2 is the angle is 45 to 90 degree and capsule clears on the medial side, okay. Type 3, the fragments are not in contact, the head displays forward and mesially due to the lateral pterygoid muscles pull, okay. So in this diagram you can see the forward displacement of the condylar head. This one is forward displacement of the condylar head, okay. Here come. Now type 4, the fractures where the condylar head articulate in the anterior position to the articular eminence, and type 5, that is a vertical or oblique fractures to the head of the condyle. Now according to the Lindahl Classification, that is based on location, so it is divided fractures into condylar head, that is this one condylar head, condylar neck, this one is condylar neck, here fractures the condylar. Now the third one is subcondylar, okay. Here it is subcondylar area, this one is subcondylar, okay. So in this diagram you see the head at the top, neck in the middle, this one is neck in the middle, and the subcondylar area is below the sigmoid notch, okay. So very commonly asked in exam. Now the relationship of fragments to the mandible. So these classifications depend on relationship of the condylar fragment to the mandible. Okay, so first one is non-displaced, second is deviated, third is displacement with medial or lateral overlap, fourth is displacement with anterior and posterior overlap, and fifth is no contact between the fracture segment. Now the relationship of the condylar head to the fossa. So it is non-displaced, displacement and dislocation. Now according to the Spilsell-Skirol classification, so type is non-displaced fracture, low neck fracture with displacement, high neck fracture with displacement, low neck fracture with dislocation, high neck fracture with dislocation, and the head fracture. So it is an important short note question. Now the etiology and clinical features. So what are the causes? So first one is intentional trauma, that is assault, and unintentional trauma like a road traffic accident and fall. So clinical features is facial trauma, pain and swelling, limited mouth opening. In fracture site the pain is palpable and posterior open bite, but here you can see the patient does not do the lateral extrusion and the proturation. Deviations towards the affecting side, bleeding from the external auditory meatus, that is a bleeding from the ear. It is very important sign. So if bleeding from the external auditory meatus, so we will suspecting the condylar fracture. Now the treatment of the condylar fracture, so it one is non-surgical. So case 1, that is a no displacement. Okay, so restriction of the movement, semi-solid diet for 10 to 15 days, then active jaw movement. Okay, now case 2, that it is a deviation of the mouth opening. So what we do muscle training, class 2nd elastic on affecting side, that is involved side, and vertical elastic forces on the normal side. So in image you can see the elastic placed on the teeth. So this elastic you see are placed on the teeth. This all is elastic. So it is you can see the elastic placed on the teeth for the traction. Now the third one is case 3, that is a fractures overriding, that is elastic traction, malocclusion, and IMF given, that is intermaxillary fixation for the 2 to 3 weeks. Now the surgical indication. So for absolute indication like fractures with a middle cranial fossa, anterior dislocation, bilateral condylar fractures plus community Leaford third. And relative indications like subcondylar plus overriding plus anterior open bite, medial displacement of condylar, and delayed treatment. So we do mostly surgical. So surgical approach. So approaches is, so incision we will not do preauricular incision, we will do modified preauricular incision and post-ramal approach for the subcondylar fracture. Okay, if there is subcondylar fracture then we do post-ramal approach. So method of the fixation. So what we do transosseous wiring, that is a double and single, bone plating, threaded pin method like Steinman method and Petzl method. So patient preparation. So before the surgery, shape the temporal region. Okay, skin preparation. Patient sagittal plane of the patient should be parallel to the tooth, that is the patient hand positioned properly, and shoulder raised with a sandbag. Okay, and the shoulder raised with a sandbag. So you can see the diagram, fixation using a metal pin and the wire. Okay, this is a metal pin and wire. Okay, this one is sutures we done. Okay, with a wire. So various method of the fixation of the condylar fracture. So this one is fixation technique, that is any long pin or long screw inserted through the ramus segment and fixed with a wire. Okay, long pin or leg screw is threaded through the ramus into the condylar segment. Third one is Petzl technique. That Petzl technique, it introduced a sophisticated technique of fixation. He drilled a hole from the inferior surface of the ramus and then inserted a pin into the condylar segment. So you see, drill his hole like this. From here, drill his hole from the inferior surface of the ramus, and then we inserted a pin into the condylar. So this one is pin, okay, into the condylar segment. After the reduction is done, the pin is cut and nut is placed in the end of the pin and tightened to offer the compression effect at the fracture site. So you can see a pin passes upward and compression is applied, okay. So this is a pencil technique. Now the operating step. So first, that is a modified preauricular incision we gave for TMJ assist. Now what will the step is, a blunt retractor is inserted and locating the zygomatic arch. Now the inferior border depression is present. So inferior border depression is present where there is a mandibular joint. So the assistant move this mandibular joint. So fragment will also displace. Now transfer the facial artery found. It should be cut and tied. Then L-shaped incision is made on the lower border of the zygomatic arch to the outer border of the ramus. Then the next procedure should be depend whether it is lateral displacement or medially displacement. So you see a laterally displacement. First one is strip periosteum, okay. Place the condylar retractor, okay. Place the condylar retractor, then drill the hole. Like this, you see diagram. This one is drilling the hole. Okay, this one is drilling the hole, then passing the wire and grasp the hemostrat. This one is wire is passed from this drilling the hole. Then after the drill the ramal fragment. So here you see we will drilling the ramal segment, then pass the wire here and then reducing the fracture. So passing the wire of the here to here, okay. After passing the wire, we will reducing the fracture. Then IMF given, twist and cut off the wire. So you see the whole diagram show the drilling and wire fixation step by step. So students, today we discuss all classification, clinical features, treatment, surgical step. If you found this video helpful, like, share and subscribe to Exam Key Point Dentistry. Thank you so much. See you in the next video.